Okay, so my name is Collins Harrell. This is my family. This was a few years ago. This is more current over here. My wife and I have been married 26 years now, and it's been awesome. We've had a great time. We have four boys, and our oldest was married almost a year ago, October of last year, to our first daughter. So we have a daughter-in-law now, and maybe we'll have granddaughters someday. And everybody's like, "Didn't you want to have a girl?" I always wanted to have a girl, but we got four boys, and they're awesome. And my third oldest just graduated high school, and he's leaving to go to college. So we actually only have one son left at home. We're kind of coming up on being empty nesters, but we've got 3 more years with him. He's a sophomore in high school this year. So this is my little family, and I am a general dentist. I practiced in San Clemente in Southern California, about halfway. It's a little beach town halfway between San Diego and Los Angeles, for almost 20 years. Had one of the best dental teams on the planet. Just really love these gals. They're like my family, and super awesome time. I started doing ortho. Let's see, I started my training, I think back in 2007 or 2008 with Progressive Orthodontic Seminars. So those of you who are brand new, who've never taken any classes with Progressive Orthodontic Seminars, welcome, you're gonna love it. It's an awesome company. They have awesome education. I think that my orthodontic education is probably the best thing that I did ever in my career, besides becoming a dentist, for so many different reasons. So kind of when the 2007, 2008, when the economy kind of slowed down, especially, the cosmetic work in Southern California, I looked at ways that I could increase my bottom line and keep some things in the practice. And I realized that I was mostly referring orthodontic patients, above endo and oral surgery and perio and all that stuff. I was referring a ton of orthodontic cases, had lots of young families in the practice. And so I decided that I would like to understand more about ortho. I had done a little bit with Invisalign, but not much, just enough to know that I knew how to get in trouble and didn't really know what I was doing. And I wanted to be able to talk intelligently when I would sit down and examine my patients. And so I started my orthodontic education with Progressive Orthodontic Seminars and learned how to do everything, braces, and did some surgery cases, and just really, really, really enjoyed my work. I think it made me a much better dentist. And so that was in 2007, 2008. In 2017, I started having some real dexterity problems in my hands and found out that I had a pretty severe bony growth growing into my spinal cord, causing cervical spinal stenosis and caused permanent damage, which I wasn't aware of until the damage was already done, and had a lot of breakdown disease on other levels as well. So I had to have surgery to relieve the pressure from my spinal cord. And they said, your other levels are bad enough that if you go back to doing dentistry, which is kind of what caused this, was the way I sat in the chair and, held my head and whatever. They're like, you're going to have multiple level surgeries in a couple of years. And so I made the difficult decision to sell my practice and retire from clinical dentistry. My family, along with that, we made a decision to just make a major life change. And we moved from the beach where we lived and surfed and did all the beachy Southern California things to a little town in Southern Utah where we live now, which is near Zion National Park, if any of you have ever been there. It's called Cedar City. And here we have a little bit more land and some animals, and we go snowboarding up in the mountains and go hiking. And so life has been a little bit different. I've had the great opportunity to be able to become an instructor for Progressive Orthodontic Seminars and traveled quite a bit before COVID hit. Ever since COVID, it's pretty much all been webinars and online seminars. And so I've learned how to teach in front of a camera in my room here. But I get to do a lot of one-on-one case consulting and mentoring with doctors who are doing ortho through Progressive Orthodontic Seminars. So that's me in a quick nutshell. Next time when we get together, I will ask you guys to introduce yourselves. We have some doctors who are visiting today, and so we may not have as many next time. Hopefully you'll all decide that you are interested in learning more about, some of you maybe have never done ortho at all, and the idea of doing an orthodontic case in your practice is brand new. Or maybe you've done a little bit of work with aligners like I had, and enough to realize that you kind of don't know what you're doing and you want to improve your ability to treat your patients, improve your confidence, your skills, your understanding. Some of you may have been doing braces and you want to increase your aligners. So on this webinar, we're going to have people from all kinds of different backgrounds. And I'm going to try to teach to the level of somebody who is a doctor, who's a general dentist with no experience in orthodontics, where the idea of doing ortho is brand new. So questions are welcomed. You're welcome to type in the chat. You'll see that I already gave you my email address in the chat. It's collinsharrell@icloud.com. I try to keep an eye on that chat box while I'm teaching so that if you have a question or comment, I see it. But you will also have the ability, everybody's used Zoom now, I think, but you have the ability to raise your hand. So if you go under participants at the bottom of your screen, one of the options it gives you is to raise your hand. So you can raise your hand if you have a comment or question. You also can email me, so if after the webinar you want to have a question answered, if it's a good question, I'll probably keep it for the next time we get together and answer it for everybody. But feel free to reach out to me via email if you have a question. The other thing that we do for you at no charge in these webinars is if you have a case that you'd like to start, if you think that you found a good case for your level of experience, and you just want me to take a quick look at it and say, yeah, this would be a good case for you to do aligners on, or no, this would be a really challenging case for these reasons. If you just want to email me whatever records you have, photos, if you have x-rays, that's great. Eventually, we want all of you to be able to take a lateral ceph. We'll talk about why throughout the seminar, but that'll be part of your records. But for now, I understand you probably would only just have some photographs. So if you have photos, some clinical photos, and you'd like me to take a quick look at a case and just give you my thoughts on whether it would be an appropriate case for you to take on either as a first aligner case, or maybe you've only done a few, or maybe you have a lot of experience. So if you kind of share with me your experience level and the photos, I'm happy to just take a quick look and give you my opinion on that case.
Collins, may I just interrupt for a second?
Yes, please.
Some doctors are having an issue activating their videos. It apparently is stating that the host needs to activate the video.
I haven't heard of that one before. Let me look and see.
No, I haven't. And this is Dr. Amosak, and he uses Zoom a lot, but I don't know if he needs to log out and log in and out.
Hang on just a second. Let me look and see. Yeah, I can. It looks like I did have the option to allow people to start their video. So let's see if that allowed people to start their video.
Thank you.
Thanks for the heads up. Okay, so let me share with you my screen, and we'll get into webinar number 1. So this is webinar 1A. And Yvette or Gabby, can you just give me a thumbs up if you can see my presentation full screen? All right, cool. Thanks. It's not in the presenter mode. Awesome. All right. So Aligner Plus, this course has been named Aligner Plus, and the content has been created by Dr. Dana, David Dana, who is our clinical director at Progressive Orthodontic Seminars, and his friend, Dr. Daniel Lazani, who's an orthodontist that has done, thousands of aligner cases per year. He's got lots of great experience doing aligners. Dr. Dana is a prosthodontist who does tons of ortho, and they just, between the two of them, have a lot of great experience. So these are not my cases, and I'm going to be sharing cases that they've put into these seminars. But they wanted to call it Aligner Plus because we want to stress that it's not just aligners that we're going to be using to be successful. Okay, we're going to find that aligners alone have some weaknesses, and to overcome those weaknesses, we want to be able to use auxiliaries that we will be teaching throughout these webinars and that you'll learn about in your self-study at home. Auxiliaries like these buttons that you can see down here in this photo at the bottom of the screen that allow you to attach an elastic to the teeth and pull teeth in certain directions to try to pull them into the aligner. Elastics to try to, class 2 or class 3 elastics, where inter-arch elastics, where we're trying to coordinate arches. And sometimes we need to put brackets on, either at the beginning of a case or during a case or at the end of a case to accomplish something that we're having a hard time doing with aligners
就放
alone.
在你的广告，
So
放在你的广告。
好久好久之前了，那去年的事情。
everybody real quick here. All right. So that's the idea with Aligner Plus. We're going to be talking about, as we go through the seminars, different things that we can include with our aligner treatment. I mean, in some cases we can do with just aligners, but there are cases where we're going to want to incorporate other auxiliaries to help us be successful and confidently take on aligner cases. And that's why we named the seminars Aligner Plus. So just to kind of get the orthodontic juices going, I encourage your participation here as we look at a couple of pictures. We're going to show you a few cases before and after, and just ask you, do you think that this doctor treated this case with aligners or with traditional orthodontics? So here's a first case. What are some of the things that those of you who maybe have a little bit of orthodontic experience, what are some of the orthodontic conditions that you see present in just this one photo? We're not looking at the full set of records right now, but what do you see in this photo that you can tell that we're going to be dealing with if we take on this orthodontic case? Why don't you just type it into the chat and I'll read them as I see them come up. Got anybody brave? Type in the chat here. There's a lot going on in this case. Thanks, Jeff. Yeah, we have an anterior crossbite. Okay, which suggests maybe we have a little bit of dental class 3. We can't really see what the posterior occlusion is, but a lot of times when we have an anterior crossbite, we're dealing with a skeletal or dental class 3 or both. What else? I see anything else? I'll throw a couple out there. We're definitely dealing with a little bit of crowding, right? A little bit more in the upper arch, it looks like. We're dealing with asymmetrical gingival architecture. If this patient came into our practice, which happens a lot of times in a general dentist's office, where a patient comes in and maybe the chief complaint was, hey, I don't like this dark margin on this crown, and I'd like to see about getting a new crown. And at some point, some dentist made a crown for this tooth in this position, and they made a crown for this lower incisor as well, and made a crown for this upper canine, right? So we find ourselves as general dentists, if we don't do orthodontics in our practice, we find ourselves doing cosmetic work, restorative work, and having to basically just put the restoration in the position where the tooth currently is, which is not an ideal position. So this patient might have come in with just a chief complaint of, I'd like to replace this unesthetic crown that has this gray line at the gingival margin. And that opens up an opportunity for us to talk about ortho. And instead of just doing one crown, we end up doing an orthodontic case, aligning all of the teeth, and then doing multiple crowns to make the smile very aesthetic. Dr. Yuki, thank you. We suggest a midline shift. Absolutely. Do you see the upper midline and the lower midline don't line up with each other? And just from this one photo, we don't really know what that means. We don't know, is this upper midline not in line with the patient's face? If we could see the patient's face, we might find that that upper midline is shifted off to the left or to the right. And that part of our orthodontic treatment is going to be try to get the upper midline lined up with the face. Or maybe it's the lower midline that's not aligned up with the facial midline. And so maybe the patient has a shift of the mandible. They function to the left or to the right. In this case, it would be to the right if there was a functional shift. There's a little bit more overjet on the left side in the back compared to the right side. So there could be a functional shift of the mandible to the right, or there could be dental asymmetry, like all of the teeth in the lower arch could be shifted around the jaw towards the patient's right side, or it could be a combination of those things. So we have to, as diagnosticians, to understand a case, we have to diagnose that and decide what has to move. Is it the upper that needs to move, or the lower, or both? Or can we even move it at all? Is it even a goal of treatment in this particular case? So yeah, great eye, a midline shift. Okay. So let me show you the after photo. Okay. And ask you the question, do you guys think that this case was treated with orthodontics, traditional orthodontics, or with aligners? You can type it into the chat, give your best guess. Pretty nice case. One of the things that, we talked about this gingival architecture that would have been really difficult to try to make an aesthetic looking smile. And so in order to get the gums at the right level to make it aesthetic, which really the doctor did a great job with this case, is what we call torque. It might be a new word for those of you who are new to orthodontics, but controlling the buccal lingual position of these roots on these anterior teeth are going to change the height of the gingival architecture. Okay. Now, aligners are not as good at controlling the buccal lingual position of the roots compared to braces. Okay, and we'll talk a lot about that later. When braces go in and grab the teeth with brackets and metal wires, we're able to put a lot more twist or torque into the tooth to position those roots the way we want them buccally or lingually. But in this case, you can see there was really good control of the torque. And that might be one reason that if I didn't know, I would say I thought this case was treated with traditional orthodontics, because there was really good control of the torque and created some very nice gingival architecture by getting the buccal lingual position of the roots all aligned properly. And yes, Dr. Yao noted here, the midline discrepancy went uncorrected. See, we have the upper midline here. So I'm going to assume that if we saw this patient's face, which we will on our very last webinar, we'll look at this case in more detail. The upper dental midline actually was aligned with the facial midline, and the lower one is actually off. And there is a small functional shift to the patient's right side. And there also is dental asymmetry. So all of those teeth, maybe a primary tooth was lost early. It allowed everything to shift in such a way that without extracting teeth, there really was no way to shift all of the teeth back around the arch to be able to line the lower midline with the upper. And so sometimes we just, cases, especially in adults, end up not being perfect, but they end up being very acceptable. I'm sure this patient was very happy. And frankly, we don't smile with our teeth together. And so having that lower dental midline line up with the upper is actually not a really high goal for us. We definitely want that upper midline centered with the face as much as possible, but the lower dental midline is not quite as important. So that's one of the things that was not able to be corrected fully in this case, was that lower dental midline. Okay, so Jeff's going to guess traditional ortho. I probably would have guessed traditional ortho as well. This case was treated with aligners. Okay, and so I really like this case for aligners. They were able to, with the crowding in the upper arch, advance those upper teeth and correct this crossbite. Again, unable to correct the midline because of dental asymmetry, but I really like the torque control in this case. I really like how the roots were aligned in such a way that it allowed the bony architecture and the gingival architecture to look nice and aesthetic, so that when this crown was replaced, you can see that margin looks much better. It really makes for a really nice smile. And I'm sure the patient will eventually want to replace that lower crown and replace this crown and start to build an even more aesthetic smile. But I think that's a great aligner case. And one that can really show us that we can be quite successful with aligners. Doesn't mean that this necessarily want to be your first aligner case, but definitely a case that could be done successfully with aligners. So let's look at another one. Okay, what do you guys see in this case? Some similarities to the last case. What are some of the orthodontic conditions that we see in this case? Everybody's typing away frantically. No takers, nobody? We have an anterior crossbite again, right? Got some crowding again. Thanks, Jeff. Super eruption of the mandibular anteriors. So if we kind of draw a line, you can see that there's a some over eruption of those lower incisors, absolutely. And almost some over eruption of those upper incisors when we look at the position of the gingival zenith apically. That's not in a good position compared to these laterals, right? So those upper centrals are probably over erupted, as are the lower incisors, which is contributed to kind of a little bit of deep bite right here in the front, even though those lateral incisors are not in a deep bite position at all. So it looks like these upper incisors need to be intruded, right? So anterior crossbite, yes, thank you. Midline shift, we have some crowding. Midlines are closer this time, right? Not quite as far as they were in the last case, being off. So we'll see if they'll be able to line those up. But again, whenever they're off, the question is it the upper midline that needs to move in order to look better with the facial midline, or is the lower midline off? Is there a functional shift? Is there dental asymmetry, skeletal asymmetry? There's a lot going on there. Here's the final result of this case. Okay, what do you guys think? Was that treated with aligners or was that treated with traditional orthodontics? Dr. Yuki earlier said ortho, traditional ortho. Okay, in this case was actually treated with traditional ortho. In fact, it was an upper anterior alignment case only. They didn't even treat the lower. So if you look at the lower picture, even though we have, positive overjet now in the front, nothing was done on the lower arch. Lower arch is exactly the same. It was just basically a minor alignment of the upper anterior teeth using some braces. And those upper incisors got intruded. You can see that there's a much better position of the gingival architecture on those upper incisors. And even a little tiny bit of like dental open bite in those upper laterals, okay? One of the things that you're gonna find as we look at orthodontic cases compared to aligner cases is, going back, aligner cases are gonna tend to create a little bit more of a deep bite. So whenever you see a case that was treated with aligners, you're gonna see that trying to get the bite to open is more challenging with aligners. And with braces, bites tend to open sometimes even more than we want them to. Okay, so we're gonna talk about later on how aligners are very good appliances for dental open bites. So if we have mild to slightly moderate dental open bites, aligners are a much better appliance to close that dental open bite in the front compared to braces. But if we have a dental deep bite and there's a lot of overlap of the front teeth, aligners are not as good at opening that bite, and braces are better at opening that bite. So one thing that we're going to talk about, the difference between braces and aligners much better for and braces better for controlling deep and harder with aligners. Okay, so this one was treated with traditional ortho. Got a nice result in both cases. This one, they were able to get the dental midlines to line up a little bit better. Again, we're not giving you full records here. We're just kind of getting the juices flowing a little bit. We're not looking at the full set of records to see what the posterior occlusion looks like and what was done there. This one, we're going to give you a couple more pictures. Okay, there's a lot going on here. So what do you guys see? Go ahead and type it in the chat. What are the orthodontic conditions that are having to be addressed in this case? There's a lot to choose from. You want to take a stab at it? Thanks, Jeff. Class 2 in the posterior occlusion, okay? So looking at this molar back here, let me get my pen. This cusp right here should be like way back there. And each one of these cusps right here should be back here. And this canine should be back here. So you can see that we have on the right side, significant amount of class 2, probably 5-6 millimeters of class 2. We have a lot. How about on the left side? This cuff should be way back here. This one should be back there. Okay, so again, both sides have a pretty significant amount of class 2. So maybe like 4 to 5 millimeters on the left and 5 to 6 millimeters on the right side. Okay, so class 2 is a really big component of this case and has to be treated. If it's not treated, the patient's gonna end up with what we have right now, which is, Jeff saw the severe overbite, right? So we have overjet and overbite, right? So we have a dental deep bite, can't even see those lower incisors, they completely disappear. So the patient probably has a deep curve of SPE, right? Kind of over erupted lower incisors, over erupted upper incisors. So very deep bite, and also overjet. Hey, we have excess overjet because of the dental class 2. Good. What else is going on here? We have some underdeveloped lateral incisors. Okay, those lateral incisors definitely are not full, mesial distal width of those is not ideal. So we'll find that's called a Bolton tooth discrepancy, a Bolton tooth size discrepancy. Bolton analysis is one of the things that we look at with ortho. Those of you who use Invisalign has a tool in their ClinCheck where you can actually see the Bolton measurements that the computer does for you to compare the sizes of the upper teeth to the sizes of the lower teeth. And sometimes they don't coordinate well. Sometimes we have excess tooth mass in the upper or excess tooth mass in the lower, so that the teeth, even if we get everything perfect class 1, we still have coordination problems because we have tooth sizes that don't match. Okay, and this is pretty common where we have slightly underdeveloped lateral incisors. And so that creates a tooth size discrepancy where we're probably going to struggle with having some space distal to these upper laterals if we get the canines into perfect class 1. So either those laterals are going to have to be restored to a larger size, or we might have to finish with a little bit of class 2, or we might have to do some IPR. We might have to remove some tooth mass in the lower to match the tooth sizes of the upper so that they correlate better and coordinate better with one another. So tooth size discrepancies, deep bite, we have some crowding, some misalignment, some deep curve of SPE, and a lot of class 2. So do you guys think, I will show you the result. There's the result. Okay, nice class 1 occlusion. Deep bite was not fully corrected, but significantly improved. That's much better. Okay, it's still a little bit deep, but it's way better. Class 1 occlusion, and you can see this big embrasure space that we're dealing with, kind of because of these tooth size discrepancies. Okay, but super fantastic result. Like, I've been doing braces for a long time, and if I see a case like this, I go, oh dang, this is a tough case. That much class 2, it's predictable to treat 2 to 3 millimeters of class 2 using elastics, and we'll talk about how with aligners, the different ways that we have to treat class 2. But without doing something extreme like extracting or using a functional appliance, correcting more than a couple millimeters of class 2 becomes pretty challenging and pretty difficult. Okay, so how was this case treated with all of that class 2? What do you guys think? Was this done with traditional orthodontics, or did somebody do this with liners? Can we treat that much class 2 with aligners? Is that something you want to do in your practice? Yeah, Jeff goes, well, we're talking aligners. Maybe it was done with aligners. Okay, this case was treated with aligners, but the class 2 was corrected with a functional appliance before the aligners went in. So one of the things that you're going to learn about in, I don't remember which webinar it is, but it's in seminar number 3. So it's down out there a little ways. We've broken the seminars into smaller webinars. But you're going to learn about what's called a MARA, stands for Mandibular Anterior Repositioning Appliance. Okay, it's a fixed functional appliance that goes into the patient's mouth, and it causes the patient to bite into kind of an edge-to-edge bite for about a year. As the patient's growing is the right time to use it. And it helps fix the deep bite. It helps to get the dental classification to class 1. And it helps a little bit to improve a profile if they're a little retrognathic. It'll help to remodel things a little bit in the temporomandibular joint. It doesn't make the mandible grow bigger, but it does reposition the way they hold their mandible, the way it functions. So it can improve a facial profile. So this was one of those aligner plus cases where something besides aligners was used. It wasn't braces, but a mandibular anterior reposition appliance was used for a year, got the patient to a dental class 1, and then the rest of the case was treated with aligners. And so we'll talk more about these types of things, and we'll talk about different ways that we can treat dental class 2 and, you know, different amounts of class 2 and how we're going to use the aligners, or maybe how we use something besides aligners to treat the class 2 before we go and put the aligners in to finish up the case. Nicholas mentioned the carrier. Yes, that's one that we're going to talk about in seminar 4. Okay, named after the doctor who invented it, Dr. Carrier. If you want to get a head start, you can Google the carrier, spelled like this, the carrier motion appliance. Okay, and that's another one of those appliances that we can put on a patient before we put the aligners in. That you know, doesn't work in every single case, but in the right case, it can be a good option for correcting more than just a couple millimeters of class 2. So we can get to a class 1 platform before we put the aligners in. In fact, Henry Schein bought the rights to use that appliance, or to distribute that appliance here in the US. And they have their own aligners, and their tagline that they're pushing for their aligners is AP first, meaning anterior posterior alignment first, which means get the case to a class 1 before you start using the aligners. So, but it's an effective appliance, in addition to some of the other appliances that are out there, functional appliances. And then you look at aligner companies like Invisalign, and in their teen, one of the things that they offer is actually some wings that are built into the aligners that do the same thing that the Mara does, where it causes the patient to not be able to bite the way that they normally would bite, and it positions their mandible more forward. And so you can actually accomplish some of these things even using just the aligners, if you're using, you know, a company like Invisalign that offers that. Other companies don't offer that, but you can put in something like the Mara appliance before. So yeah, we have a lot to talk about as we go through the webinars in regards to addressing dental class 2. But yes, we can definitely treat dental class 2 with aligners. Okay, here's another case. Similar in some ways to the previous one that we just looked at. So what do you guys see? What are the orthodontic conditions that are going on in this case that we're going to have to treat, whether we do aligners or traditional braces? What do you guys see? Some real similarities to the previous case. We have pretty significant amount of class 2 again, right? And molars, we probably have 4 to 5 millimeters of class 2 on the right. And we probably have 5 to 6 millimeters on the left. So again, we're up above that like 2 to 3 millimeters where it's going to be predictable to do with just aligners. And I know we haven't talked about how to do that yet, but we will talk about that. Okay, so there's a lot of class 2 in this case. Yep, Jeff, class 2, division 1. Look at all that overjet, right? Those upper incisors look like they're kind of flared out. Tons of overjet. Okay, looks like the arch form's kind of constricted. You know, like it would be nice to expand those bicuspids out and kind of round out this arch form, just from what I can see in these photos. We have some deep bite, not quite as much as we had in the last case, but we still have deep bite to deal with. We've got crowding. We've got irregular wear. Look at the way these lateral incisors have worn. Okay, they're kind of flattened off. And so that's something we're gonna have to deal with as we line these teeth up, is irregular wear. In fact, I'll mention right now, those of you who have never done an aligner case, every case that you do an aligner case on, before you take a scan or an impression to send off to an aligner company, is a great idea to take a flexi disc or a handpiece and try to create regular incisal edges on all of the anterior teeth, and even canines, you know, cusp tips, everything in that aesthetic zone, upper and lower. If you can try, like you might have a canine on one side that's really worn down and flattened off, and the canine on the other side has never been touched because of the way that the patient bites and the way that they move their teeth around. They've never worn down the canine on the left, but the one on the right is, you know, completely worn down. And so when you try to line those up and make that smile aesthetic, it's really hard when you're dealing with very asymmetrical looking teeth on the left versus the right. So I might pick up a handpiece and try to take off some of that sharp point on the one side to try to make it a little look more like the other side. The incisal edges, I'll try to make those nice and flat and smooth and perpendicular to the long axis of the tooth. Okay, so that as we line up all the roots and straighten up all the teeth, all those edges start to align with each other. It's a lot easier for the technician who's doing the digital setup to give us a good setup when the teeth are going to have symmetrical sizes. You know, one's not super short and worn down and the other one has never been touched and is really long. And it's like, well, do I line up the incisal edges or the gingival zenith? You know, and I've got a tooth that, you know, on the distal, it's got an edge that's never been worn, and on the mesial, it's really worn down. So trying to get those incisal edges to all be nice and straight, symmetrical with the opposing tooth on the other side, and getting the incisal edge to be perpendicular with the long axis of the tooth before we take our impressions and scans is really helpful. So how was this case treated? Let's look at how it came out. Pretty nice result again. Okay, going back to that, looks like a pretty difficult case. Lots of class 2, crowding, arch form, deep bite, and look at how it came out. Bite, you know, perfect amount of overbite. We don't have that deep bite anymore. Okay, we got a nice class 1 occlusion on the patient's right side. Not quite so much on the left. It's definitely improved, but we still have a couple of millimeters, you know, maybe 2 millimeters of class 2 still remaining on this left side. Lower midline's off a little bit, okay? But that's a lot of class 2 to correct. Do you guys think this was done with aligners or traditional ortho? And Nicholas says, non-extraction, great result, because we have all of our bicuspids present, right? So we didn't extract any bicuspids, but interestingly, this case was treated with extractions. You just can't tell. It was treated with traditional ortho. Upper 7s were extracted. So this is actually now an upper 8. This is a third molar that is coming in to replace an upper 2nd molar that was extracted on both sides so that the patient could wear headgear with open coils to drive these teeth back. So the class 2 was corrected with appliances to push, to distalize in the upper to try to get it class 1 by extracting molars back here to allow some distalization of these teeth and then allow the 3rd molars to erupt in the place of those 2nd molars. We'll talk about different ways that we can extract cases to fix class 2 in a different webinar. Okay, but here's another case that was treated with kind of a lot of the same as the first one that we looked at, that was done with aligners, only this one was done with traditional ortho. Still got a great result. It's a little bit different. You can see that the case treated with aligners struggled with that deep bite. And the case that was treated with braces, you can see that the deep bite was no problem. Okay, so again, I'll reiterate that braces do a better job with deep bite cases and aligners do a better job with open bite cases. And we'll talk a lot about that as we go through these webinars, okay? But hopefully you're starting to see that aligners can do an awful lot. We can treat similar cases with braces or aligners. And we used to consider aligners to be more just like, you know, simple appliances that could just tip teeth a little bit. But when we learn sound orthodontic principles, when we understand the weaknesses, the limitations of the aligners, and we use auxiliaries where needed, when we understand how to treatment plan and diagnose a case properly, and we set it up properly in a digital setup so that the proper things are being done in the aligners, we can successfully treat cases. And, you know, initially we don't want to do difficult cases. Initially, we're going to want to take on cases that are appropriate for our level of experience. But as we have successful cases and build confidence, we'll be able to start taking on more and more complex cases and eventually be able to treat a wide variety of orthodontic cases with aligners. This is that patient. You can see why they chose to try to treat non-extraction. You know, even though there was an extraction done on the upper, taking molars out up here didn't really change the patient's profile, but you can see why they didn't want to extract bicuspids, because when you look at her profile, she's a little, well, she's a lot concave, right? When you draw a line between her nose and her chin, her lips are pretty far back behind that line. So she's pretty concave. And here she is after treatment. You can see there was actually a little bit of improvement in the profile. Her lips look a little bit more full, not a significant difference. Okay, but when you look at these photos and you look at all the crowding and you realize that they made a decision to treat non-extraction, they did not extract bicuspids, it was to try to preserve her facial balance. Okay, and we're going to talk about why that's so important, because yeah, we want straight teeth, but we don't want to make people look worse. If somebody has a concave profile, we don't want to extract teeth and make it so that then now their lips are even further back and they've become more concave than they were to start, right? We at least want to preserve what they have, if not improve it. And her profile improved by the way that this was diagnosed and treatment planned. Okay, so diagnosis and treatment planning is huge. And what we're going to stress in a little bit is how the fact that the aligner companies are not going to make these decisions for you. You know, they're not going to decide whether you should extract teeth or not extract teeth. They're not going to look at a patient's profile and say, oh, well, the case should be treated this way. They're going to do whatever you tell them to do, which is why I got myself into trouble before I got an orthodontic education, because I had no idea what to do, right? I just wanted the teeth to be straight, but I had no idea what was the proper way to get that patient to have straight teeth and make them look great. And in really simple cases, it worked out fine, but in more challenging cases, it didn't. So what do you guys see in this case? What's going on with this young man? What are the orthodontic conditions that we are treating here? Nicholas said distalization should be predictable using aligners. Yeah, we're going to talk a lot about distalization with aligners. It can be predictable with aligners, okay? It's not always going to be predictable. It depends a lot on each individual patient. And we'll go into, you know, which patients it's going to be predictable on and which ones it's not, and how much it can be predictable. But yes, you can do distalization in the upper arch with aligners. So we'll talk about that in an upcoming webinar. But yes, absolutely, we will be using aligners to distalize in the upper arch to help us fix class 2. Good question. So what do you guys see in this patient? What's going on with this young man? Definitely have a lot of crowding, right? And it's hard to put a number on that without seeing the occlusal view of the arches, but you can see and appreciate that there's crowding going on here. Posterior occlusion's not bad. I mean, he looks like he's, you know, a solid orthodontic class 1, maybe even a little bit class 3. But it's not going to be hard to get this patient to have an orthodontic class 1 when we're already pretty close to that position. So not a difficult case when you look at, you know, those previous cases where we're like, wow, there's 5 to 6 millimeters of class 2. How are we going to treat that, right? Jeff says an orthognathic profile. Yeah, there's a lot going on with this patient's profile that we need to address with this patient's ortho, right? This is one of those cases where the treatment decision is going to be largely dictated by this patient's profile, which is very convex. Okay, we have lip protrusion. Okay, it looks like his lips are sticking out really far. Okay, so with him, protrusion reduction is going to be part of our treatment plan decision. Like, I think even if you haven't done a lot of ortho in your practice, you could appreciate that if we have crowding in the anterior and we just align the crowding, the teeth are going to have to come more forward in order to align, which is going to make his lips come even further forward, which is going to make him look more protrusive, more convex, right? You can see that he probably even has some lip strain, like he's having to use his mentalis muscle to get his lips together. If he were to completely relax all of his facial muscles, we might find that his lips are not even sealed without him having to use facial muscles to get them sealed. So he's lip incompetent. Okay, so if we just align his crowding, yeah, we could get the teeth straight and have a class 1 occlusion, but is that going to be the right thing to do given the fact that he can't get his lips around his teeth without forcing them together and that his lips stick out too far? Probably not. Okay, so what are we probably going to have to do in a case like this? We're probably going to have to take out some bicuspids to allow us to align the crowding and retract the incisors back so that he can comfortably get his lips closed, and we won't be adding to the protrusion, right? We're going to improve his profile, make him look better, and get the teeth straight. So good observation there, Jeff. Appreciate that. One of the other things that you can see here is the tapered shape of his incisors. You see how when you look at the embrasures, it makes you think that these roots must be going like this. And then you look at the periapical x-rays or the panoramic x-ray, and you find that those roots are actually straight up and down. They're parallel with each other. And so you realize that, oh, we're actually dealing with some teeth that have some tapered anatomy to them. And when I line these teeth up, we may have to tip these roots more to the distal in order to get this embrasure to have the right size so that it's not a giant embrasure. Okay, so sometimes in these cases, we're also dealing with tapered central incisors, tapered lateral incisors. They don't have an ideal shape, so that we can't get the roots perfectly straight and have the teeth look great. We have to tip the roots in a way that compensates for the tapered shape of the crowns. You can kind of see that here, where that embrasure is still pretty big. That's one of the things in the finish that kind of jumps out at me, is like, I'd like to see a little bit more distal tipping of those roots to try to get these crowns to tip a little bit more to the mesial so that we can reduce that embrasure space right there. Okay. But this case was treated with bicuspid extractions. Okay, you can see we're missing bicuspids here and here. And they would have treatment planned this case to do a maximum amount of retraction to try to really change his profile, which they did. You can see now he can get his lips together, right? His lips aren't sticking out as far as they were. Okay, do you guys think this was treated with aligners or with traditional ortho? Can we do extraction cases and maximum retraction with aligners? Jeff's thinking maybe extractions followed up by aligners. So this case was actually treated completely with aligners, okay? And some of the things that you're going to see when we learn about extractions, okay, you're not going to do this until you have a lot of experience with aligners. But remember, we keep talking about how the bite tends to deepen with the aligners, and you can see how this patient actually got a deeper bite. See where it started? The bite is not deep at all, okay? And if you look at the torque of the teeth, they're very flared in the front. And then look at how it finished, and the bite got deep, and the teeth look a little bit tipped back, or we will call this retroclined or detorqued, okay? So you're gonna find that, yes, we can close extraction spaces with aligners, but the aligners have some weaknesses. They're weak in controlling torque. So it becomes very easy to make these incisors look tipped back. It's difficult to maintain a good torque position. It's one of the things that we're going to talk about when we learn about how to do extractions with aligners, is how to overcome these weaknesses. So the bite got deep. The incisors look like they've been kind of shoved back. They're a little bit detorqued or tipped lingually. And you'll see that these upper molars have tipped. Those roots didn't really come with them. They're kind of, the crowns tipped more to the mesial and the roots stayed further back. So it's harder for the aligners to get good control over the roots when we're doing a lot of movement. Okay, so yes, we can treat an extraction case with aligners, but there are weaknesses with treating. It's always going to be better with braces. We're always going to do a better job with braces when we're extracting. But what if the patient is demanding aligners and they need to have extractions done? Well, if we have enough experience and we realize that there's going to be some compromises and some weaknesses, we can still treat that patient using aligners. So we'll talk a lot more about extractions in an upcoming webinar. Just throwing some ideas out there right now. This one was treated with aligners. Here's another one. It's got some similar features. Was it treated with orthodontics or with aligners? Okay, again, this young man has got a lot of protrusion. His lips are sticking out even further than the previous patient. He's retrognathic. His chin looks like it's insufficient. He hasn't gone through his pubertal growth, so he's got growth coming. He could improve his profile and get more of a chin just by his natural growth. But for sure, we've got, he can't close his lips without using his facial muscles. He's lip incompetent. Incisors are very flared. There are some spaces, but there's also some teeth blocked out. Like this is a primary canine right here. That's got to come out. That's a primary canine. There's the permanent one back there. This permanent one's probably up here somewhere. Okay, so this is a mixed dentition patient. We're not in full adult dentition yet. Okay, we actually still have primary molars in here. They look like adult molars, but those are actually primary molars. Okay, a lot going on with this case. We got some deep bite, we got a lot of flaring, we've got overjet, we've got class 2, we've got mixed dentition, protrusion. He was in treatment a long time. Look, he grew up during treatment. It's probably a phase 1, phase 2 kind of thing. Those are probably records at the beginning of phase 1, and then these would be records at the end of phase 2. So in my eyes, that looks like he went from being about, I don't know, 10 years old to being about 15 years old. So I doubt he had braces on for 5 years, but now we've got some little mustache hair here, and he looks like he's grown more of a chin here, but look at those lips. Okay, they're still a little bit protrusive, but he looks very good. He has very nice facial balance compared to where we started. He has lip competency. He's able to get his lips together. Okay, so what do you guys think about the finish? Was this treated with aligners or was this treated with traditional orthodontics? Okay, we had bicuspid extractions done. You can see that we're missing bicuspids. We got a nice canine class 1 occlusion on the right side, not so much on the left side. So maybe this patient, he was 15-year-old boy, 14-year-old boy, probably wasn't very compliant when he was asked to wear elastics to try to get these arches to coordinate well. Or maybe one side was more resistant than the other side because this is his dominant chewing side over here. But what about the deep bite? We don't have really a deep bite problem. If anything, there's a little bit of an open bite problem. And what about torque? Does it look like these incisors got shoved back? Well, not too bad, actually. They actually have pretty good torque still. Okay, so this case was actually treated with traditional ortho. It's not a perfect result, right? Braces, it's not like, well, if we do aligners, we get a less than perfect result, but if we do braces, we're gonna get a perfect result, right? We struggle with braces too. Braces have weaknesses. Relying on patient for cooperation has weakness. So there's no perfect appliance. It's just understanding if we use this appliance, what are the benefits? What are the strengths of that appliance? If I use this appliance, what are its benefits? What are its strengths? Where am I gonna run into weaknesses with different appliances? And if we do a good job with treatment planning, diagnosis, coming up with a good plan, we can successfully treat these cases, whether we do braces or aligners. Is this a retainer? Hopefully you guys can see that this is not a retainer, okay? You might have patients that come into your practice and say, hey, my friend had some crooked teeth and they got a retainer and they got their teeth straightened with their retainer. Okay, this is not a retainer. This is an orthodontic appliance that looks like a retainer. It looks like a Holly retainer, but it has an active arm on the lingual side that's applying pressure to move the teeth towards the buccal. And then there's an arm of acrylic out here that has shape in it to try to receive those and give a stopping point where they might get more straight. Okay. So what we want to stress here is anything that moves teeth is an orthodontic appliance. And one of the challenges with aligners is patients, doctors, up until kind of recently, even the insurance companies have kind of looked at aligners as being more of a cosmetic appliance. It's kind of like doing some veneers. It's just a cosmetic thing. It's not really real orthodontics. But anytime that we're applying a force to a tooth and we're moving teeth, whether it's with something that looks like a retainer or not, we're doing ortho. So anytime that we're delivering something to a patient that's going to move their teeth and deliver orthodontic appliances, we are doing real ortho. Okay. And Dr. Dana, when he put these slides together, kind of on purpose said orthodontics or aligners, to kind of irritate us a little bit, because really it's not different. There's not a difference between orthodontics and aligners. If I say traditional ortho, meaning fixed appliances, braces, brackets, that's one thing, right? But anytime that we're using aligners, we are doing orthodontics. So it's not orthodontics or aligners. It's, you know, fixed appliances versus removable appliances. And anytime that we're doing ortho, we have to treat the case as an orthodontic case with the same respect that we would give if we were specialists, okay? So with progressive orthodontic seminars, one of the things that we teach and that we practice is we as general dentists need to be practicing. If we're gonna do ortho in our practices, if we're gonna do aligners, which is an orthodontic appliance, we need to be doing it at the level of a specialty, okay? Whether or not we ever get sued, whether or not we ever get called in and we have to, you know, defend ourselves, I mean, that may never happen. But the bottom line is we want to make sure that we are doing the same thing that the specialist would do. So the records that I'm going to take should be the same records that an orthodontist would take. And even though the aligner company, those of you who may have already done some aligners, even though they're not going to ask you for a lateral ceph, they're going to assume that you have one, because every orthodontist who does any ortho on any patient is going to have a lateral ceph. It's part of the standard of care. It's part of the baseline records that are taken for a case. It's like doing a root canal on a lower incisor, but you're like, well, I didn't get a PA because, you know, it's just a lower incisor. I assumed it would be pretty straight. Or it's just an upper incisor. I assumed it would be a straight canal, so I didn't take a PA. So we're going to want to learn how to take records at the level of the specialty. And another reason for that is I'm a general dentist, right? I'm going to tell my patient that I have specialized training in ortho. I do a lot of ortho, but I am not an orthodontic specialist. I don't limit my practice to ortho. If you would like to go see an orthodontist, there's some great ones in town. I would love to give you a referral to some of the ones I like. And most of the time patients are like, no, if you do, we're comfortable with your office. We like you, we like your staff, whatever, we'd like to have it done here. But every once in a while you get a patient or a parent who's like, yeah, you know what, I think that's a good idea. We would like to get a couple of opinions and then we'll decide. And a lot of times they end up choosing to have it done in my practice. But when I allow them to go see an orthodontist, or maybe they just choose to on their own, they're going to want to take the records with them, right? So when I send my records, if they don't look like the records that a specialist would take, then they can tell that in my practice, I'm doing orthodontics at a subpar level. Right? I don't really know what I'm doing. I'm not doing it at the level of the specialty, and they can see that right off the bat. And so then that backs up in their mind what they think already, which is you shouldn't be doing ortho. But if my records come over and I have the same records they would have taken, nicely done records, a good treatment plan, a well thought out diagnosis and treatment plan, then it's like, hey, you know what? I don't love that Dr. Harrell down the road is doing ortho. I'd rather he not be doing ortho, but at least I can see that he's doing ortho at the level that me as a specialist would be doing it, right? Whether I agree with it or not, at least I'm practicing at the level of a specialty. So that's what we hold ourselves to, is to say, hey, if we're going to do ortho, maybe the first couple cases you need to get set up, you need to get, figure out how you're going to take a lateral ceph in your practice. You haven't bought the machine yet. You're going to use a mobile clinic or some clinic or some imaging center that's in your town. Okay. Or you're going to work out a deal with the specialist who has the lateral ceph so that you can get some records taken. Okay, there's lots of different ways to figure out how to get this done, but that's going to be part of doing ortho in your practice, is getting set up, getting a system in place to be able to do it at the level of the specialty. Okay. Just another example here of a removable Holly retainer that has an active appliance portion of it that's moving a tooth. Anytime we're moving a tooth, it's an orthodontic appliance, and we have to treat it with that kind of respect. And we don't ever try to move teeth without taking full records, okay? So one more before we move away from this conversation. One more case we'll look at real quick. What do you guys see going on in this case? And do you think it was treated with traditional ortho or with aligners? Well, I see some pretty thin gingival tissue. Look at the gingival tissue on these canines. Pretty thin, maybe even a little bit thin on these lower incisors. But look at all the crowding. There's a lot of crowding here. So am I going to be able to align this crowding in this lower arch without stressing this tissue and causing recession? Okay, we've got excess anterior overjet. We've got kind of a tapered looking arch form. That looks like maybe those bicuspids could be expanded and round out that arch form a little bit. Okay, posterior occlusion, it's a little bit of class 2, not much. If anything, it gives me a hint that this patient maybe has, if we saw his face, maybe there's a little bit of class 3 in his skeletal balance. But looking just at the teeth, we've just got a little bit of class 2, but a lot of crowding. And I'm really concerned about this tissue, the thinness of the tissue down here. Here's the case completed. You guys think that was treated with traditional ortho or with aligners? Okay, you can see bicuspids were extracted, mainly because of that thin tissue, right? We didn't want to cause recession by aligning all of that crowding into thin tissue. So bicuspids were extracted. Bite got a little bit deep. Teeth look a little bit detorqued. Upper molars look a little bit tipped. The crowns look like they've tipped to the mesial. So those are the weaknesses of the aligners. It's a beautiful case. I would be thrilled if this was my extraction case in my office and I did this with aligners, but you can still see the weaknesses of the aligners there, right? Okay, so this is another case that was treated with aligners. In fact, this young man, you can see that little bit of class 3. See in his final picture here, you can see that he grew. But the starting picture here, you can actually again see some stippling in his chin, like he's having a hard time getting his lips around his teeth. And here at the end, even though he still looks a little bit class 3, he at least looks comfortable in the way his lips come together. This young man was headed off to college. He was still growing. You know, boys can grow up to age 18. He was headed off to college and was unable to be to come in for regular exams and visits. So the decision was made by the treating doctor to use aligners, and then it was monitored over FaceTime calls, photographs, and then the occasional time when this patient was home for Christmas or you know, one of the holidays to get checked up on. So that was a pretty incredible case to carry out long distance, and it was done, you know, with not really seeing the patient that often except for virtually. So again, there are, you know, aligners have weakness, but look at the strengths too. You know, the strengths allowed this to be treated without even coming into the practice that often. So how many more cases might you be able to do in your practice when you're not having to manage all the work that brackets can be, and you're able to see the patient less frequently? And if everything goes well, it almost takes care of itself. You know, I can basically get a case started and let my assistant manage the case, and all I ever do is just give the patient a high five when they're walking down the hall while I'm cutting a crown in the other operatory, right? So yeah, it has strengths and it has weaknesses. One of the weaknesses is the patient can remove them, okay? One of the strengths is the patient can remove them. It's nice to be able to remove the aligners, but it's also a weakness because now they have to be compliant. I can't come to their house and tell them all the time to get their aligner. And I'm treating, you know, 2 of my sons right now with some aligners, and I'm like, dude, get your aligners in. They're always sitting on the counter. So if we understand the strengths and weaknesses of these different appliances and then treat them as orthodontic appliances, right, with the respect that they deserve, with full records, doing things at the level of the specialty, we can be really successful with aligners. One of the things that we have to understand with aligners is we're going to send the scans or the polyvinyl impressions to the aligner company, whatever company we're going to use. They're going to digitize it. They're going to come up with a, you know, a 3-dimensional setup where they're going to straighten the teeth for us. And then they're going to send it back. You know, Invisalign calls it a clean check. Excuse me. Some companies call it a digital treatment plan, but whatever it is, it's going to be a movie. You'll see it here in just a minute, one of the slides. You're going to get this movie back that simulates the teeth getting straight. And it's going to have a series of steps in it, and every step is going to represent a new aligner. So each aligner in the series is going to have a slightly more straight position to the teeth. And as the patient goes through and wears these different aligners, it slowly forces the teeth into a new, more straight position. Okay. So when we send these to the aligner company, we just say straighten the teeth, they're always going to be able to send it back with straight teeth. And when we watch the little movie, we're always going to see the teeth get straight and we're going to get excited and we're going to go, hey, this is going to be great. You wear these aligners and your teeth are going to get straight just like I saw in the movie, right? In the little digital setup or the ClinCheck. The problem is just because we can move these teeth straight in digital world, in digital space, doesn't mean that that's going to happen in the patient's mouth. Because in the patient's mouth, we have cortical plate, we have bones, we have roots that are limited in where they can move by the bones. And so in digital space, there's nothing stopping us moving a tooth 8 millimeters. But in the patient's mouth, is that really going to happen? And if we don't understand where these bones are in relationship to each other, then we don't understand how far we can move the teeth before it's going to start hitting restrictions. Where is the skeletal resistance? Where is the point at which the root says, I can't go any further because this is where the bone stops. And if you keep trying to move me, all I can do at this point is start to tip over or procline or flare out, which is going to cause an unaesthetic position to the tooth and it's going to cause recession, right? So the setup will always come back with straight teeth, but is the patient going to be happy with the way the teeth look? And are the teeth really going to move the way that the digital setup is showing them to move? Is that realistic? Are we going to be happy with those results? So here's one example. Okay, imagine you've done a couple of aligner cases in your practice. They were fairly simple cases. You gave the patient the aligners and, at the beginning of the case, you had some crowding. And at the end of the case, the teeth were straight and you're like, wow, it worked really good, right? So then another guy walks in your practice and you look in the mouth and you go, oh, I see crowding again. I have fixed crowding before with aligners. I just put the aligners in and I tip the teeth straight and they get straight. So I should be able to do this again for you. But I don't understand ortho. I don't take full records. I don't really know what's going on here. I just see crowded teeth and I'm going to give you aligners and assume that's going to work. Well, what's going on in this patient's mouth? He's skeletal class 2. Okay, that means that his skeletal base of his maxilla and his mandible, they don't relate well. Okay, so he's class 2 in that his bones are in a class 2 position. Okay, so these lower teeth are already very tipped. And the upper teeth don't have to tip as much. They're of a more normal position because the bone is in a normal position, but the bone is very far back. So if we don't take a lateral ceph, we don't really know where his bone is. We can guess, but we don't really know. And we don't really know what inclination his lower incisors are already at. And we have a lot of crowding. How much crowding do we have here? Well, the way we count crowding just quickly is we count broken contacts, okay? We just kind of assign a millimeter to each of the broken contacts, starting at the mesial of the first molars. So here I see a tooth that's kind of blocked out. So we're going to give that 1. And then we'll go 2, 3, 4. This one is about a half a 1 to me. That's about a half a 1 to me. So I've got 1, 2, 3, 4, 5. So I'm going to go kind of like 6 millimeters, maybe 5 to 6 millimeters of crowding in the lower arch. And if his lower incisors are already tipped really far forward because his bone, his mandible is too far back, he's skeletally a class 2. And so his lower incisors are already tipped as far forward as they can go. Look at the tissue. Tissue's kind of thin, especially on those canines. How much further am I going to be able to tip those before they're very unaesthetic, unstable, which means they're going to relapse really quickly, and I'm getting recession on them, right? So the doctors started treating this, didn't really understand, got a digital setup back where the teeth got straight. Okay, they moved these teeth without tipping them in the digital setup. They just moved them out here. Okay, but the problem is that there's no bone out there. When you look at the actual patient, you're like, well, the tooth can't move where there's no bone, right? I can't move a tooth into a position where there is no bone there. And so things were not going well. And the patient wasn't sure that things were looking and feeling right and went to an orthodontist. And the orthodontist said, you know what? You really needed to have extractions. This bicuspid and this bicuspid should have been extracted along with some upper bicuspids, and you should have been treated as an extraction case. And now this patient who's being treated by his general dentist is upset, has lost the confidence within that doctor, and leaves the practice. And the doctor's frustrated and upset because now he's lost a patient. He doesn't look good in front of the specialist. And it leaves one of those bad feelings where you kind of go, maybe I don't want to do ortho in my practice. And we don't want you to have these experiences. We don't want you to have an experience where you're like, I kind of got started in ortho. I had a bad experience. I just don't think I'm going to do it. I'll just let the specialist do it, and I'll just do other things. We want you to pick cases and understand your cases so that you can be successful in your case selection, in your diagnosis, in your treatment planning, in getting help along the way to make sure the case finishes properly, so that you can have some good experiences where the patient's happy, your staff is happy, and you actually made some money. And then you're going to go, hey, that was good. I liked it. It was good energy in my practice. It was fun. I made money. It was rewarding. I want to do more of that. Those are the kinds of experiences we want you to have, not the experiences where it leaves a bad taste in your mouth and you don't want to do any more ortho. Okay, so here was this patient's actual lateral ceph. Okay, so his lower incisors are already tipped really far. And remember, we had like 5 or 6 millimeters of crowding to align. So if you look at the little simulation right here, it says, well, if I've got all that crowding, I'm going to go from my incisors in this position to my incisors in that position. That's not going to look right. It's going to create a dental open bite. It's going to create incisors that are flared and recession and anesthetic. Okay. And then so the patient loses confidence and goes to somebody else. So if we're not taking lateral cephs, if we're not understanding the cases and all we see is just, oh, there's crowding, I can fix crowding, we're going to be successful some of the time and we're going to be unsuccessful some of the time, and we're never going to know which case is going to be which, right? So we want to help you guys have good experiences diagnosing, treatment planning, understanding your cases, getting help along the way. Okay, so consulting services, mentoring services, until you get to the point where you're confident in your skill set, in your knowledge, and you don't need the help of, we don't want you to always be dependent on a consultant or a mentor, but having a consultant or mentor really helps you be able to sit and talk to a patient confidently, even though you just started doing ortho, and say, hey, I think this is, a case that we can do successfully in our practice. I'd like to take a little bit of time and look at it. I'd like to take some pictures. And in your mind, you're thinking, I'm going to send it off to a consultant or mentor. I'm going to have them look at it with me. They're going to come back and say, yeah, this is a good case for you. Or they're going to say, no, this isn't a good case. In which case you go back to your patient and you go, hey, when I really sat down and looked at your case, I found some things that made me think that this case would be better treated by a specialist. So off we go to a specialist, right? Or you come back and say, hey, I sat down and looked at your records and I think this would be a great case. I would really like to be able to provide this service for you. Let's get the rest of the records that we need to send it on to the aligner company. And now you have the confidence of knowing that you have somebody to help you make these decisions. And then when you get a setup back, you're going to have somebody help you look at it and make sure that it's done right. Okay, so all setups are going to end up with straight teeth, but it doesn't mean that the teeth in the patient's mouth clinically is actually going to move like that, and that you're actually going to get the result that they showed you you're going to get in digital world. So if you've never seen a setup, this is what it looks like. Okay, this is actually a clear, correct version of a digital treatment plan. It's pretty simple. There's not a lot of tools here to look at on this one, although some of the companies have quite robust software, and there's a lot of things that you can look at. But let's just look at the simple version of what's going on here. You can see in this one that there's 33 aligners. Okay, and at 2 weeks per aligner, that's going to give us about 16 or so months of treatment. So about 1 year and 4 months worth of treatment. You can see that this patient has already had ortho because there's bicuspids already missing. Okay, so this is an ortho relapse case. So if we just hit play on the movie, you're going to watch, it's going to go through these stages and you're going to watch how the teeth are moving. Okay, so let me just play this for you. Okay, so what I just showed you is actually not how I like to evaluate these setups, because I don't find that anything really looks unreasonable when it's moving very slow like that. Okay, so when I hit play and it just goes at this speed, everything just looks very reasonable because they're all just very small movements. Nothing really pops out at me as being a problem because it's all just going really slow. But this isn't an actual, like I'm not in the actual software, so I can't really move it the way I want to, but I can go and slide this movie a little bit faster. So watch if I go back to the beginning. And what I like to do is I like to grab the little slider and I like to slide it back and forth really fast. So let me try and do that with the movie here. And you'll find that when you slide it back and forth a little bit faster, things will start to pop out to your eye that you didn't see when it was going slow. Like, is that a realistic amount of expansion? If I picture where the cortical plate is on the buccal side of those upper and lower molars, is that realistic for this adult patient who's probably in their 40s or 50s? Is that realistic for me to expect the aligners to move the teeth that far to the buccal where there is not any bone? No, it's probably not. But when I was watching the movie really slowly, it didn't look that unrealistic because it just happens so slow. But when I move the slider a little bit more fast, I go, oh, geez, I don't know. That doesn't seem very realistic to me. Okay, and there's a lot of things that we're going to look at, and we'll talk more in another webinar. We're just kind of introducing this right now, but we'll talk about how we're going to evaluate these setups. We're going to look at each of the different attachments, decide whether it's necessary, decide whether we like when they placed it, where they placed it. We're going to look and see if there's other teeth that maybe are moving in such a way that they should also have an engager. So we'll teach you guys in these webinars, what these engagers do, what orientation and position they should be in to accomplish what types of movements. Okay. We'll look at staging. We'll look at, are they moving this in a way that is realistic? Okay. I'm watching these lower incisors. I'm watching the upper incisors. And initially, when you have really, here's the one from the occlusal view. Okay. So you can really see that expansion that I was talking about. And you're like, well, I don't know. I mean, if that's the arch form, I don't know if that is realistic. And I'm also retracting those incisors back. What does this patient's face look like? Are they going to look better if their lips come back a little bit? Or are they going to look worse if their lips come back a little bit? Okay, so we'll talk all about how we evaluate these setups to decide whether we like what the technician has done or whether we don't like what the technician has done and we want to ask for some changes. Okay, but this is what a setup looks like. And if we approve it, then they make aligners to match each one of the steps in this setup here. So this doctor asked for a few changes to the way it was staged, and look what they got back. A new setup with 10 aligners. Well, is that better? Is it better to have 10 aligners or is it better to have 33 aligners? And how can we do the same thing in 10 aligners versus 33 aligners? Okay, so we're going to talk about the speed at which we move teeth and what speed is predictable for the aligners. Okay, we're going to talk about how far we can move teeth and how to know, like in one patient's case, it might be really reasonable to try to expand as much as you're seeing here. And in another case, it might not be reasonable at all to try to expand that much. Okay, but all I want you to understand right now is that it's going to be very helpful for you to have a consultant or mentor, somebody who's looked at these setups a ton of times, to be able to look at your setup for your patient and go, hey, you know what? They did this and this really well according to our instructions, but I don't like what they did here and here. So let's ask them to change that. And we're going to keep asking for changes until you're happy, your patient's happy, and your consultant or mentor is happy with the setup. And so if we get a good setup, now you know that, yeah, you're still going to struggle because we always do with ortho, but at least you're going to that patient with aligners that are going to be a lot more predictable. You're not handing them aligners that are trying to do things that are completely unrealistic for that patient, or that might move their teeth in a way that is going to make them not look as good. Even though their teeth are getting straight, it's making their profile look worse. Okay, so evaluating these setups and understanding these setups is a big part of being successful in aligner treatment. And that's where you're going to be able to get help from a consultant or mentor. And what's cool about it is, it's like, remember in dental school, the first time that you looked at a bite wing and you're like, I have no idea what I'm looking at. Like, I'm supposed to be finding cavities. I'm supposed to be finding, caries. And I don't even know what is what on this x-ray. And if somebody points out to you where they see interproximal decay, you're like, oh, okay, I can kind of see that. And the next time you look at it, they kind of start to pop out to you a little bit. And then after you've been looking at bite wings for 10 years, you throw a set of bite wings up on the viewer and you can instantly see everything. It just, everything pops out at you. You see all the things that are normal and you see all the things that are abnormal because you've just looked at so many. And these setups kind of like that, where initially you have no idea what you're looking at. You don't know what's right. You don't know what's not right. It just, to you, it just looks like, I don't know what I'm looking at. And so as you have a mentor consultant look at these setups with you and suggest problems and things that could be improved or things that could be changed to be more predictable or better for that patient, those things will start to pop out to your eye, so that when you start looking at setups, you'll start to see things that you never used to see because you've been borrowing somebody else's eyeballs for a while. And all of a sudden it just starts to become a lot more clear to you. And you're like, oh, I remember before when they were moving things like that and we didn't like it, they suggested this change. So my mentor suggested that I request this change by using this wording. And when it came back, it was fixed. It looked better. So I'm going to use that wording next time I see that problem. I'm going to, start to understand how to communicate with this technician who's not a doctor. It's just somebody who's been trained in the software to try to move the teeth the way that we've asked them to move it. Okay, they're not making treatment decisions for us. They're not deciding what the best way to treat the case is. They're just trying to give us what we're asking for as the doctor in a way that we're going to be happy and approve the case so that they get paid for it and they get to make it and move on to the next case. Dr. Yao said, meaning we won't get to be independent. So our goal is not to keep you guys dependent on mentors or consultants. Our goal is to have mentoring or consulting available to you to help you until you don't need help. Okay, to help you be successful. Ortho is one of those things where I kind of liken it to like learning how to sail a sailboat. If you sit in a classroom and you just get taught how to sail a sailboat, but you've never sat in one and gone and tried to sail it, you don't have any way to understand what even is being talked about. But you still have to have enough knowledge to at least go out and start sailing on a boat. And then once you're out sailing, everything starts to make more sense, right? And then as you go back to class and learn, it's like, yeah, I remember that, that makes a lot of sense because I remember trying to do that. And so ortho's that way. It's not like, when you do a crown prep, you pretty much have to know how to start and finish that procedure because you're going to sit down and start it on a patient and finish it. Ortho is going to be a 12 to 18 month procedure. So during that 12 to 18 months, it's like learning how to sail. And you're going to be going, hey, I'm learning how to do ortho because I'm doing ortho cases in my practice. But I also know I'm not going to screw anybody up and I'm not going to get myself in trouble because I'm using somebody to help guide me and answer my questions and help me make the right decisions so that I'm learning as I'm doing. And after I've done enough cases, I feel very confident doing this type of case, right? Or I would like to expand the types of cases that I can do. So, I'm really going to encourage you guys that if you like ortho and you want to learn how to do more and more ortho, that you would take the full series of courses from Progressive Orthodontic Seminars where you learn how to evaluate lateral cephs and make all of your own treatment decisions so that you can do everything without any consultant or mentor. Okay, where you can say, hey, I want to treat everything that comes into my practice, whether the patient wants braces or whether they want aligners, whether it's a difficult case or an easy case, I want to feel confident treating everything that comes in my practice. And some doctors do that, okay? And yes, you become independent of any consultant or mentor. Other doctors are like, I just want to do the cases that I find productive in my practice, where I make money, it's predictable, and I know how to recognize the cases that are good. It's kind of like I do some endo in my practice. I don't do every root canal that comes in the door. Right? I know which ones are going to be effective, fast, predictable, and make me some money. Right? And so when I see them, I'm like, yeah, I'll do that root canal right there. That one, no, refer it out. I don't want to do that one. That one's going to make me lose money. I get frustrated. I get upset. That's a hard one. And so some doctors are like, hey, I have a busy GP practice. I do a lot in my practice. I don't need more stress in my life. So I'm going to learn how to identify the cases that are great cases for my practice and treat all those. And I don't really need a mentor consultant because I've learned how to do the cases that are within this realm. And the rest of them, I don't find them productive in my practice and I refer them to a specialist. Okay, you're going to find what works for you. Some people love to treat everything. Some people love to find just that perfect sweet spot where it's fun, it's productive, but they don't do the hard root canals. They don't pull the hard, wisdom teeth. They don't treat the kids that are hard. It's a nice thing about a GP. You can do as much or as little as you want to do. So our goal is to help you be confident in learning ortho, confident in getting some experience, and then you get to decide how much you want to. I have some people that I work with where they send every case to me because they just enjoy having somebody else work with them. They enjoy another set of eyes, somebody else to bounce ideas off with. They enjoy the learning experience. And then there's other doctors who maybe use a consultant or mentor for 1 or 2 cases, and they're like, hey, you know what? I got this. Like, I don't want somebody else involved in my stuff. So everybody's different, and you'll find what works best for you. Definitely, our goal isn't to make you dependent on a consultant or mentor. Our goal is to help you and support you in being successful and getting experience so that you can do as much or as little as you want to do. Does that make sense? I hope that answers that question for you. So why are we talking aligners if braces work so well? Why, if braces are working, why go with aligners when you get better compliance with braces since they can't take them off? And the reason for that is because it's changing. The world is changing. And what our patients are hearing through all of the advertising that's being done is that, hey, the new way to do it is aligners. The best way to do it is aligners. Whether we agree with that or not, which I don't necessarily agree with, because I think braces are awesome. But we have to be willing to adapt and provide what patients are asking for, or we become obsolete like some of these companies did who didn't kind of keep up with the trends and where things are going. Okay, so if we want to stay relevant, we need to be offering aligners in our practice because that's what patients are being told by all the marketing is the new and best way to do it, and they're willing to pay for it. And frankly, in my practice, I offer both. I'm like, hey, I do braces, I do aligners. In your case, I think the braces are going to work better, or I think the aligners are going to work better, or I don't really think there's an advantage to one over the other. Here's the fee for the braces versus the aligners. Here's the strengths and the weaknesses. And I want them to choose. If they choose to do aligners, it's because they think that's going to be a good fit for them. And then if they're not getting good results, like, well, you chose aligners and you have to wear your aligners for them to work and it's not working for you. Let's put braces on and finish it up. Right. And so I like being able to provide braces and aligners for my patients, but you guys may be at a point where it's like, I just am getting started. I'm just starting to dabble in aligners. I've done a little bit. I want to get better at it. And so I don't really offer braces an alternative. I just refer the cases out where braces would work better or the patient wants braces. And I'm going to kind of cherry pick those cases that are going to be really good aligner cases where I know the patient's motivated, they're going to be compliant, and it's going to work out well. Nicholas says, in my part of the world, the cost of the aligner is cheaper than what ClearCorrect is offering. So what sort of mentoring could I get independent of the aligner company? You guys are going to find in the self-study. In fact, when we get to the end of this little webinar tonight, I'm going to show you how to go onto our software, which is called SmileStream, and where you're going to find your self-study material. You'll also get an email at the end of each of our webinars that's going to give you links to that self-study. But in the self-study, we're going to go through what's offered to you with mentoring and consulting independent of any aligner company. Okay, so you can get mentoring or consulting services just directly from us. And regardless of, some doctors are using in all different parts of the world, we have Angel Align, we have SureSmile, we have Invisalign, we've got ClearCorrect, we've got doctors who are making their own aligners in their practice. I mean, I'm consulting and mentoring with all kinds of different aligner companies. And so whatever aligner company is going to work best for you financially in your part of the world, you can still get the mentoring or consulting services. Consulting is $300 US dollars per case. And that's going to include the workup, the diagnosis, the treatment plan. And if I'm doing it with you, it would be going through the first initial setup with the aligner company and making changes to the setup until we're happy with it. And then once you approve treatment and you get started with your patient, that's where the consulting stops. Mentoring is you continue to use me for any questions or problems you have throughout the treatment until you're done with the case. So if you have to do a revision, which is where we get new aligners, to finish up the case from wherever we got with our first set of aligners, then I'm there to help you with the new setup again, with new instructions to finish the case, or to look at photos and say, hey, I can see that tooth's not moving the way we thought it would. Let's try this auxiliary. Let's do this, and come up with ideas to get teeth tracking well. So mentoring costs $600 per case. Consulting costs $300 per case. And that there's a part of your self-study is going to have all of that information for you. Okay. But yeah, the services are available regardless of which aligner company you use and whether or not, you could even make the aligners in your own practice. So yeah, talking about self-made aligners, would you recommend us to do so once we are done sufficient number of aligners? To me, that's, it's a really, like some doctors will sit down and go, I find it cost effective to make my own crowns. And somebody else goes, I don't have time to make my own crowns. I don't want to deal with that equipment. I don't want to deal with that software. I don't want to deal with having to spend the time doing that. I'm going to use a lab to do that stuff for me. And so I've never in my own practice owned the equipment or the software to be able to make my own aligners, but it is getting cheaper and it is getting easier to do. So if you're one of those people where you like, making stuff in your own practice, it may make sense at some point for more straightforward, simple cases to use software, like, I'm blanking on the name of it right now, but there's some software out there that allows you to make your own aligners. And then you just produce them in your office by making a 3D model. And then you just make suck down aligners on it. And there are doctors doing that. I find that for the amount of aligner cases that I want to do and the number of aligners that need to be made, it's just not cost effective for me to have a production lab in my office. I'll let somebody else produce them for me. But I know other doctors where they're very happy with it and it works out really well for them. So there's a lot of different ways to go about getting aligners right now. Lots of different companies providing lots of different plans and lots of different pricing. And I realize that you're going to find what's going to work best for you. And in certain parts of the world, Progressive Orthodontic Seminars does have deals with certain companies to try to get, so where you're part of a family of doctors where we get, group discounts basically. And so we can pass those on to you either by giving you the consulting for free, or we can give you a discount on the case, but we're kind of like ordering the aligners as a big purchasing group. So just depending on where you're located, you'll be able to figure out, Gabby or Iveta can help you with that as well, since I don't know what all different.
Yes, I have been, and maybe we can also schedule a call with Dr. Yo just outside of the classroom, you and him. But there was a question, I don't know if you saw it, about the CEFs. It was kind of
from Jeff. To echo off of Rump, do you take a lateral CEF on all patients?
Thank you.
Yes, I take a lateral CEF on every patient that is an aligner patient. Okay. And it just kind of is like when you don't, oh, I see that was up there before. Do you take a lateral CEF on ortho cases? Yeah, sorry, I missed that. So yes, in my practice, I purchased a digital lateral CEF. Okay, so it was a digital pan CEF. And frankly, as a lot of people right now are moving towards cone beam, CBCT, they're getting rid of the digital pan CEFs. So actually you can pick up some pretty nice digital pan CEF machines used on the market that are in great shape, but it's just because a doctor's like, hey, I do a lot of endo, or I do a lot of implants, and I needed a CBCT. So I got rid of my digital pan CEF and I brought in a cone beam. So if you're not at a place where you want to have a cone beam in your office, because those can produce, if you get the right size, if you get one that can do the whole head, you can get a really nice lateral CEF image and panoramic image off of a CBCT. But if you're not looking at investing at that level, there is a lot of really nice digital pan CEF equipment out there that's available. But I purchased a digital pan CEF machine for my practice. And it's kind of like once you have it, you find that you use it all the time. So any patient in my practice who was interested in ortho, that was just part of the records. Doesn't matter if I'm moving one tooth or all of their teeth. Anytime I'm going to be doing ortho on them, that's part of my baseline records is photos, models, and panoramic x-ray and a lateral ceph. So yes, please consider that is a requirement for ortho cases. I realize again that you may not be in a position right now. You have some cases you're doing that you'd like help with, or that you would like to start that you'd like help with, that are simple, straightforward cases. You don't have a ceph, but I need you to look into ways to get lateral cephs, because you'll need to be taking lateral cephs if you're going to really be serious about doing ortho in your practice. Okay, so getting back to the seminar here, good questions, guys. But why aligners? It's because our patients are demanding more cosmetic appliances, and they're willing to wear them. They're willing to even pay more for clear appliances. There is a huge opportunity in your general practice, okay? One of the things I love, especially during economic downtimes, is as a GP, you don't have to wait for referrals to come in, right? Like an orthodontist specialist has to wait for you to send them cases. You have a huge opportunity. There are people that walk through your doors every single day who are potential aligner patients, but you don't ever bring up ortho. And so it's not something that's done in your practice, but there's so much opportunity. Our practices are gold mines of opportunity. Okay. The majority of orthodontic cases are not detected because we are not diagnosing and talking about ortho because we don't have the orthodontic knowledge. The Academy of General Dentistry said back in 2003, which is a long time ago, it's probably a lot different now, but even then, only about 10 to 20% of orthodontic problems were being diagnosed. You know, and as a general dentist, we sit down and we diagnose fractures, we diagnose, fillings or crowns or restorations that are bad. We diagnose decay, we diagnose periodontal disease. We do all of this screening, but we don't ever really screen for and diagnose ortho. If it's a younger patient, the parents are asking about it, we might go, oh yeah, you know what, you should probably go see the orthodontic specialist. But if you go patient by patient who comes into our practice, it's not generally until we start doing ortho, doing an ortho evaluation and diagnosing the orthodontic condition and prescribing treatment for their orthodontic condition is not part of what we do. But imagine if we didn't diagnose caries, or if we didn't diagnose fractures, or if we didn't diagnose periodontal disease, right? But orthodontics is not just a cosmetic thing. It's not just, oh, if you want your teeth to be straight, it's a nice thing to do. I talk to my patients about how, if you go and buy a new set of tires and you don't align your wheels, those new tires wear out unevenly and quickly because they're wearing unevenly. They're not aligned properly. When my wheels are all aligned properly, the tires wear very well. They last a lot longer because the wear on the tires is even. So with our teeth, when our teeth are misaligned, it causes periodontal problems. It causes wear problems. You'll have certain teeth that are breaking, certain teeth that are getting abfraction lesions. There's a lot of wear and tear that happens when our teeth are not well aligned. When they are well aligned, we'll still get wear and tear, but because everything is aligned properly, it's more spread out and more even. And so the wear is much slower and our teeth last a lot longer. The periodontal health is much better. We're able to clean and maintain the bone and gum between the teeth much better. So it's more than just a cosmetic thing. It's not like, hey, well, if you want straight teeth, we can straighten your teeth so they look good. No, it's a functional thing. It's a health thing. There's a lot going on with orthodontic conditions besides just whether they like their smile when they smile. So there's lots of opportunities out there for us. It says here that 30% of all orthodontic treatment in the US are using aligners. That's probably a lot more now. I'm going to guess it's probably closer to 50% now. Okay, but the use of aligners is growing quickly in the US and around the world. Experts estimate that it will grow to 50% in 5 years. I think that this slide is probably pretty old and we're probably closer to 50% now. Here's a market growth analysis. So the number of orthodontic cases started in 2009 compared to 2017. The growth, or from 2009 to 2017, the percentage of conventional bracket cases, the growth in that market was 11%, and the growth in the aligner market was 59%. So you can see that the number of cases starting with aligners is growing a lot faster than the number of cases starting with traditional braces. So if we're not increasing our patient starts at the same rate, we have a lot of missed potential in our practice. So what is orthodontics? The area of dentistry concerned with the supervision, guidance, and correction of the growing or mature dental facial structures, including those conditions that require movement of teeth. Anytime we're moving teeth, we're doing ortho, okay? And the way that we do that is we apply a force to a tooth, whether it's through an aligner or through braces. Whenever we have a force being applied to a tooth consistently over a long period of time, the application of those forces stimulate and or the stimulation and redirection of functional forces in the craniofacial complex. What happens is that the body responds to those forces by starting osteoblastic and osteoclastic activity so that the bone remodels so that the teeth can move. The teeth get loose. If you've never done ortho treatment, the teeth are going to get loose, you know, whether you're using aligners or brackets. Any tooth that's being pushed on and moved is going to get loose. And that's part of the body allowing it to move. And then when we're finally done moving it and there's no more force being applied to it, over the next several months, the tooth will not be loose anymore. It'll become, you know, nice and stable in the mouth again. Our responsibility anytime that we're doing orthodontics is diagnosis, okay? We have to be great diagnosticians. We have to understand the case, understand, you know, not just getting the teeth straight, but understanding why we're moving the teeth, how we're moving the teeth, what kind of a occlusion we're forming, you know, whether we're going to be improving their facial balance, whether we're going to be giving them something that's healthier for their gum tissue based on the final position of our teeth. We have a lot of responsibility when we oversee an orthodontic case. Okay, so again, we apply a force and we activate osteoclastic and osteoblastic activity so that the teeth can move. We're eating away bone that's in the way of where the tooth wants to go, and we're forming new bone in its path. So anytime that we are applying orthodontic forces through aligners, we are doing ortho, and we need to take full records and do it at the level of the specialist. Okay, so you need to do orthodontic work at a high level because we're general dentists, we're going to be held responsible. You could be challenged someday by an unhappy patient, or just the reputation that you get when your patients go to other orthodontists in the area for a second opinion. Okay, so our ortho records need to meet and exceed the American Board of Orthodontic requirements. And that'll be in your self-study. You'll see what needs to be done to take proper orthodontic records. Okay, so professional records are required for all aligner cases and what we call a dental VTO. VTO stands for Visual Treatment Objective, and you'll understand that as we go through the SmileStream software. We make predictions about how the teeth are going to move when we can trace the lateral ceph and combine the information from the models, and then the computer moves the teeth for us to show us, you know, kind of a visual treatment objective of what's going to happen. Orthodontists are engaged in the quantification of the facio-dental complex. Okay, what's important is the facial balance as it relates to the supporting structures. Whenever we move the teeth, we're going to have some effect on the way their face looks. Okay, so we diagnose cases first by looking at the patient's face from the outside before we ever look in at the teeth and decide how we're going to move the teeth. We want to make sure that if we move this patient's teeth, we're not only making the teeth straight, but we're going to preserve or improve their facial balance and their facial harmony rather than make it worse. Okay, so goals of treatment, number one, facial balance. Okay, especially if they're growing. If it's a growing patient, we have the opportunity to really have an impact on the way that their bones grow, on the balance of their face. Okay, second, we obviously want to straighten their teeth. We also are going to try to correct the bite so that we have good harmony in the occlusion, good coordination between the arches. Okay, and that's one of the things, if you look at like Smile Direct Club, you know, they're straightening teeth with their aligners without any regards to facial balance or bite correction. Okay, so we're doing a lot more than just making teeth straight within an arch. We're making sure that the arches coordinate, that there's a good bite correction, and that we have good facial balance. That we're putting the teeth in a position that creates and maintains periodontal health. Okay, we're not causing periodontal problems by the way we've moved and positioned the teeth. That the temporomandibular joint is going to be healthy, and that we've put the teeth in a position that's going to be long lasting. Okay, we haven't put them in a position where everything is strained and tipped to the maximum amount that it can tip, so that the minute the patient doesn't wear their retainers, everything just comes slamming back and they get relapse within days. Okay, so these are all goals of orthodontic treatment for us. Obviously, the aesthetic outcome is critical for the patient to be happy, but we as the treating orthodontist, general practitioner, are going to be concerned with a lot more than even the patient's concerned about. Okay, orthodontic, orthognathic considerations essential when selecting an aesthetic treatment plan. So it's not only just the teeth, but it's also the bones and the facial structure and facial balance. Okay, we're fixing more than just the bite. If attention is directed only to bite correction, the facial balance may not improve and could get worse. Our job is to balance the occlusal correction with the temporomandibular joint function, the periodontal health, the overall stability, and the facial balance while we're moving the teeth into the proper position. Why is it important to identify a malocclusion? Okay, so as patients come into our practice, why is it important that we diagnose a malocclusion? Okay. Teeth that fit together properly, we already kind of talked about this, require less dental work. They don't get beat up as much. And so Dr. Dana is like, well, you can pay for it now or later, right? You can pay for the ortho treatment and get all your teeth lined up properly now, or they'll get beat up and you can pay for it later with crowns and restorations. Question from Ramya. Yeah, what was your question? You can unmute yourself. Oh, I see it. You typed in the chat here. Do you treatment plan aligners in mixed dentition cases? Yes, you can absolutely use aligners in mixed dentition cases. In this aligner seminar, we are not going to teach mixed dentition. Okay, we're not going to teach phase 1, phase 2 ortho. If you take our traditional ortho series, you will learn all about phase 1, phase 2 ortho, all about mixed dentition. But yes, aligners can be very effective in treating mixed dentition. Depending on what our goals are, there are sometimes we get in and do some things in phase 1 with aligners, get out, wait until they have full eruption, and then get in and do it, phase 2 with aligners as well. There's some that are transitional, where we start with the aligners while they still have a few baby teeth, but we're going to continue aligners all the way through the loss of the remaining baby teeth and the eruption of the adult teeth and the completion of the case. So, but yes, you definitely can use aligners through mixed dentition cases. And I do consult and do mentoring with those as well. Sorry, guys, I've been talking too much and not getting through these slides. Why is it important to identify the malocclusion? Oh, here we already said that one. So malocclusion is a disease, and our job is to identify disease processes in the mouth, okay? So malocclusion means bad bite. And anytime that we don't diagnose it or treat it, we are definitely not allowing our patients to have optimal dental health. Okay, my patients who have aligned their teeth, they just take better care of their teeth. They can clean them better. Their gums are healthier. When you get two bones or two roots that are too close to each other, there's no way for bone to grow in between those roots, or at least to be maintained. And so they get bone loss where there's root proximity problems, overlapping problems. When the teeth are aligned properly, everything wears better. The bone is healthier between the roots, the gum is healthier, they can clean better, they just take better care of their teeth, and their long-term health is much better. Okay, so a malocclusion should be seen as dental disease and treated as such. We should be identifying these in our practice. Diseases have progression, okay, and this is just an example of how a disease process can progress. Okay, so at age 9, 11, 12, and 13, you can see how we went from, mixed dentition where when we just had some primary teeth and a couple of adult teeth in the mouth, it didn't look so bad. But by age 13, we've got quite a problem going on over here, and we need orthodontic treatment because there's no way that this is functioning properly. And could that have been prevented? Probably. So our job is to recognize problems, prescribe treatment. If you recommend treatment, patients may feel that it's optional. If we prescribe treatment, we are making a diagnosis and making a decision on what treatment is needed. I'm not a heavy-handed guy in my practice. I'm not one who tells patients that horrible things are going to happen if they don't do ortho. They're going to die. They're going to, their mouth's going to fall apart. I don't like scare tactics. I don't like a lot of sales pressure, but I do feel like it's my job to see things, to help my patients see what I'm seeing and understand what I'm seeing, understand the consequences of some of the conditions that they have. Some are more urgent, others aren't that urgent, so I try to help them understand the urgency of what needs to be done. And then I prescribe treatment. I say, here are the things that we can do for your condition. And I like to let them make the choice. I'm not forcing the choice on them, but prescribing treatment says, I've diagnosed a condition in your mouth that is a disease. It will get worse with time. I mean, everybody, how many patients have you had say, my mom had really crowded teeth when she got older, and I'm starting to notice, I'm in my 40s now, I'm starting to notice my teeth are crowding the same way as her did. I'm just starting, and I don't want to end up like my mom with my teeth really crowded and with having to get teeth pulled. So I know I'd like to straighten my teeth. And you'll hear that a lot if you start asking the question in your practice, hey, have you ever thought about straightening your teeth? Okay. But it's a disease process. It progresses as people become older. Whether or not they ever had ortho, their teeth all tend to, move towards the front, and they tend to become more crowded over time. So what's a normal occlusion? A normal occlusion is a class 1 relationship, normal overjet and overbite, no crowding, no rotated teeth, and no anterior or posterior cross bites. Okay. How many patients are coming into your practice that look like this? Well, probably the ones who've just recently had ortho, right? And everybody else has some form of a malocclusion, and that can at least be documented, diagnosed, and you can prescribe treatment. You don't have to force people into treatment, make them feel pressured to have treatment, but you can at least help them see what you see and help them know that there's treatment that can be provided for them. Okay, crowded teeth. Crowding is a malocclusion. It's the most underdiagnosed problem in patients' mouth. Okay, crowded dentitions show more periodontal involvement, and the improvement after scaling disappears more rapidly in the areas that are crowded, according to this study. When crowding was eliminated, the patient's overall hygiene got better. Okay, 75% of the US population have some type of malocclusion that would benefit from straightening the teeth and having a more functional bite. These patients pass through our office every day, and we have so many opportunities. Okay, so the things that are most underdiagnosed are going to be crowding, dental deep bites, and dental open bites. And so we should recognize them and diagnose treatment and help them to avoid premature occlusal wear, chipping of teeth, breaking teeth, abfractions, periodontal problems, all consequences of malocclusions. What can be treated with aligners? Horizontal imbalances, okay, so dental class 2, dental class 3 cases, a canted occlusal plane, jaw joint dysfunction, excess overjet, crowded teeth, rotated teeth, tipped teeth, deep bites, open bites, cross bites, spaces, okay? You guys can treat all of this with aligners. Maybe not all of those on the same case, right? You don't want to take on really complex cases, but you can treat these things with aligners. The benefits of correcting these malocclusions are improved aesthetics, improved function, both dental, muscular, and temporomandibular joint, reduction of traumatic occlusion on the teeth, irregular wear, better gingival periodontal health, and improved tongue and lip function. So we want to stress that whenever a patient comes through the door for a filling or a cleaning or any service other than correcting their malocclusion, it's an opportunity for you for your hygienist, for your dental assistant, for your treatment coordinator, for everybody in the office to educate the patient on the benefits of aligning teeth, okay? I'm gonna stop right here on this slide because I wanna show you guys before you leave SmileStream really quick. But I just wanna stress that there are so many opportunities that come through your practice, okay? And so I encourage you to go back to your practices and say, hey, you know, get the team together. Hang on just a second. I get where I can see you guys again. I didn't manage my screen very well, and I've lost your smiling faces. Let's see if I can get it back. Oh, there you are. Okay. So get your team on board, sit down with your staff, have a lunch, and tell them that you want to do aligners in your practice, or, you know, that if you're already doing a little bit, that you're going to really increase what you're doing in your practice. But get your team excited. Find somebody in the practice who has an easy case, you know, one of your patients or a family member. I love it when it's one of your team members, because if somebody in the office is wearing aligners, you know, give them a great deal, just charge them for the cost of the aligners, but just get a case started. You got to get the excitement going in your practice. Okay, so find somebody who has just a little bit of crowding that needs to be resolved. Send me photos if you want me to take a look at it, but let's get a case going in your practice so that you can start talking to your patients like, hey, we do aligners in our practice now. You know, Judy up front has got them in right now. We're doing her treatment. And then your staff will get excited and you can start helping them to understand like, hey, this is what we're looking for. These are the conversations we're going to start having with our patients when they come in. We're going to start asking them, have you ever thought about straightening your teeth? We're going to start diagnosing, you know, like what their classification is. So at a minimum, you know, when I do that hygiene handoff and she's telling me about the broken teeth that she sees and the decay that she sees on the x-ray, and we're doing that little verbal handoff in front of the patient, she also says, you know, and it looks like there's about 4 millimeters of crowding in the lower arch and about 2 millimeters in the upper, and they've got a little bit of dental class 2. And then I look at the patient and I go, hey, have you ever thought about straightening your teeth? And they're like, well, yeah, actually I have. You know, my mom's teeth got crowded when she got older and blah, blah, blah. And you start having all these great conversations with your patients, but you got to get your team excited, get your team on board, let them know that you're doing this and that you're committed and you're all in. And, you know, just like everything, it takes a little bit of time to get the processes set up in your practice. There's a lot to learn. You know, we've only been together for a couple of hours here. We want to support you in learning all that you need to learn. But right now, I just want you to get excited and get your team excited and decide this is something you're going to do. Ramya says, do you treat existing perio patients with aligners? And if so, any accommodations when you treat them? Absolutely, you can treat perio patients. You really want to get your patients who have perio into a position, though, where there's no active periodontal disease. So if you have a patient who has had perio or has perio, you can treat them once you get to where their gums are healthy. Okay, you don't want to treat them when they have active periodontal disease. So help them get excited to get their gums healthy, whatever they need to do to get to where they're not, you know, bleeding and they're not inflamed. We don't want to move teeth in the presence of inflammation and disease. But once they are at a point where they're healthy, there are considerations, you know, depending on how far we need to move teeth, how mobile the teeth already are. It's really case by case. Sometimes I will use an aligner company with a perio case like Invisalign that doesn't cover as much of the teeth, because when they have periodontal disease, it can really be very retentive with certain aligner companies where, you know, the patient has a lot of undercuts. And so when they wear the aligners, it's really difficult for them to get them out. They just feel so tight on their teeth. So there are considerations, but yes, you can treat patients who have had periodontal disease. And it's kind of case by case as far as like what considerations do we have for that patient. All right, I want to show you guys really quick. Let me share my screen with you and show you SmileStream. So if you have not already, I want you guys to go to smilestream.com. Okay, smilestream.com. Here, I'll type it in the chat. And you're going to go to a landing page where it's going to tell you to create an account. Okay, it's a free account for you. You're going to want to create an account in SmileStream. And once you have that account in SmileStream, you're going to be able to get access to all of the content that you've paid for. Okay, and within SmileStream, you can see I've got SmileStream opened right now. You can see this is an area where we put patient records. Okay, but I just at least want you to see, you know, here when you first, let's see, let's go to the collaborate page. Once you've created an account, you're going to land on this collaboration page, which is a cool place where, you know, the doctors that are doing POS seminars are able to go in and ask questions of their colleagues, of other instructors. So it's fun to go through and read the questions that people have had and the responses that they're getting from their colleagues and from instructors. Okay, and then when you go under clinical, there is a dental module, okay, which is just kind of like the software you probably already have in your practice. A lot of doctors don't use the dental module. You guys are going to be using this orthodontic module. Okay. But it's an orthodontic module where we can go and do orthodontic exams. It's a place for us to click buttons and basically classify, diagnose an orthodontic case. You can do this chairside in your practice. You can print out these pages and you can have printed pages in your practice, but it just gives you and your team somewhere to start recording orthodontic classifications for your patients, places to put orthodontic records. Okay, and this is the software that you're going to get familiar with and that we're going to use if you're going to do ortho cases using us as consultants or mentors. Okay, those of you that are just visiting, you can create a free account. You can go on and check out the software. Those of you who have already signed up for the class or who will sign up for the class, you will have access to some information that I want to show you right now. Okay, so you'll have a username up here in the upper right-hand corner. And if you click on your username, it's going to take you to your profile page. And underneath your picture is going to be a list of all of the seminars that you have registered for and that you've paid for. Okay, so if you've signed up for Aligner Seminar 1, which is what we just started, you should have access right here to Aligner Plus Seminar 1 online materials. You'll also get a link to this same spot in the email that you'll receive from us at the end of this webinar. Okay, there's also going to be Aligner Plus Seminar 1 video recording. Okay, this seminar, rather than being taught in webinars with self-study, has also been recorded when it's being taught live, you know, for a whole weekend seminar. So you can go and you can watch a live recording of the whole thing being taught, or you can go to the online material. Okay, and there's a bunch of great information in here. How to study, general information about using consulting and mentoring packages. Okay, how to submit cases to a consultant to get help with a case, how to take records on my patients. Here is everything that we just talked about today, webinar 1A. You'll be able to go through all the slides that we went through today. And then here is all the information that we're going to want you to self-study before our next webinar. Don't worry, this is going to come to you. This link is going to come to you in an email too. Okay, but I just want you to realize that on SmileStream, you can also get to it by just clicking on your username, and it'll go to your profile page and you'll see the content that you've paid for. Okay, so you can watch the whole live seminar when it's being taught live. Or you can go in here and you can click on a recorded version of what we just taught, webinar 1A. You can click on and go through all of the self-study material. Here's what we're going to be teaching next week when we get together, webinar 1B. Okay, so I'm not going to teach you everything about this software right now. I just want you to realize that there is this software, this SmileStream software. This is the software we use to manage all of our orthodontic cases and communicate with each other as mentors, consultants, and doctors using them, you know, so that we can help each other. And then this is where you're going to get access to some interesting forums and also access to all the stuff that you've paid for and that you know, get to access and learn from. The other cool thing about progressive orthodontic seminars is once you've paid for a course, you have lifetime retakes. Okay. So if you pay for and register for these webinars and then later decide that you would like to go, you know, like we're doing a live course in Austin this weekend. We do live courses all over the US and different parts of the world. And so if we go to somewhere where it's convenient to you and you would like to go sit down and retake the whole thing live, you don't pay for it. You just show up and you can take the whole course live rather than have to go through self-study and do some of the stuff on your own. You can watch it recorded. You can go back and revisit everything that we've done together. Okay, you have lifetime access to all of this stuff. It's not just a one time and you're done. You can always go back and retake everything that you've paid for free. I think that's pretty cool. And I appreciate that they do that for us. So I'm going to stop talking. I've gone over a little bit. And again, future classes, I really try to start on time and end on time so that you guys can just know it's going to be the 2 hours that you've set aside. Feel free to reach out to me via email if you have questions you'd like me to address next time we get together. I'll type it in the chat here one more time. Okay, Collins Harrell at iCloud.com. And I really want to thank all of you for joining us. I know some of you today were just kind of checking things out, just visiting, trying to make a decision on whether this is going to be a good fit for you or not. Some of you have already registered and you will be with us next week, same time, same place. And I look forward to being with you, and we'll let you introduce yourself and get to know you a little bit better. Any questions that you have right now, though, before we end? You have me here, you've got Iveta, you've got Gabby. Does anybody have any questions about how these webinars work or what's available to you or how to register? Or any aligner questions that you really, really want to ask before we end tonight? Okay, so Jeff says, I've already paid. How can I access the SmileStream videos? So again, Jeff, just create, if you've not already created a SmileStream account, create an account in SmileStream. Gabby, go ahead.
Hey, okay, so actually you should already have an account set up for you. Tech support should have sent you an email with your username and password. Sometimes, a lot of the times our first emails go to the spam folder, so it might be in there. All our emails end with posortho.net.
I just found it. Thank you.
Awesome.
Perfect. Thanks, Jeff. And then you can always find it too, just by going, logging in SmileStream. And like I showed you, click on your username in the upper right-hand corner, and it will take you to the content that you have access to.
And then Dr. Ramia has a question. Is there a timeline?
On when I
How
can
and when?
classes? Not really. So if you sign up for these webinars, you're obviously going to want to come every Tuesday. Right now it's Tuesday night for me. I don't know where you are located, but it's going to be same time, same place every week for the next 10 weeks. We're not going to hold you, like, if you don't do the self-study, it's not like you can't keep coming to the classes. You may not understand as much as you come to the classes if you don't take the time to do the self-study. But there's not a timeline. You do it whenever it's convenient for you. You can always go back and rewatch videos. You can always go back and access the content. So whenever you are able to access the content and go through the content, you will get the certificate and the CE credits once you've completed the quizzes that are at the end of each of the 4 seminars, which we've broken up into 10 webinars. So there's not really a timeline. We'd like you to try to keep up with the class, but if that's not going to work out for you, it's not like you're going to miss out. You always will have the opportunity to go back and watch recordings, go back and access all of the content, and even go to a live seminar if you want to go do it that way. Some people find that they just do better when they set the time aside on a weekend and go take the whole weekend and do it. And others do really well with self-study combined with these 2-hour webinars every week. So content is available for lifetime.
Yeah.
It doesn't go away. It's not going to go away. If you pay and register, you will have access to that for the rest of your life. So does that answer your question? Yeah. Okay, cool.
Thanks.
Any other questions, guys? Yvette or Gabby, anything else you wanted to add?
Well, we want to thank everyone to attending. Thank you, Dr. Harrell. And again, if anybody has any further questions, you know how to reach us.
Yep, Yvette and Gabby are super helpful. So they've put their phone numbers up there. You can reach out to them by email or phone number. And also the tech support at POS is really awesome. They will help you with software problems, anything that you're having issues with. And I'm happy to help you with any clinical questions that you have through my email. All right, guys, it has been a pleasure to be with you. Thank you for being with us. I hope that you have learned something and that you have gotten excited about learning more about ortho and that you want to, you know, incorporate this into your practice and do more ortho in your practice. I hope you've been able to tell that I really love it. I'm pretty passionate about it and really would love to help support you guys and help you to have success in your practices and setting up an orthodontic part of your practice. All right, thanks guys. Have a great evening or day wherever you are, and we will see you next week, same time, same place. Bye.
Bye.
Bye.